So today we're going to talk about hip replacements. So I have with me my little hip, so I'll be using this to kind of talk through a couple things that can be talked about or discussed when having your hip replaced. So generally, the patient that would be a possible candidate for a hip replacement would be some person that's talking about having some groin pain. So most people will say, oh, my hip hurts over here, I think I need my hip replaced, but that doesn't always correlate 100% with needing to have a hip replacement. Generally, people will have more of the groin-related pain, which if you think about, again, here's our hip, here's your pubic bone, and then here, this is the starting of your femur or your thigh bone. That groin pain is right here in the front, which is right where your hip joint would be. So if you started feeling kind of this unrelenting groin pain that didn't really go away, you have more pain with walking, weight bearing, maybe laying on that side, that again increases your groin pain, could potentially mean you're a candidate. So from there, you would go to doctor's appointment, potentially have some imaging, which could indicate, again, we're trying to rule out any other possible causes and make sure it's just the hip joint itself that's causing your pain-related symptoms. So that could mean an x-ray. Some doctors will do a follow-up MRI, but sometimes with the x-ray you can kind of get all of the information you need. So when they're looking for any arthritic changes in the hip, we're looking for any changes in the ball. I'm not sure if you can see, but it's a rounded piece. And then there's the little cup that the hip sits in. So you can either have wearing down of the actual head of the femur, or you can have wearing down of the little cup it sits in. So it's just kind of round in here, your leg moves around, and if there's wearing down or extra bony development just from extra pressure in the hip joint, that can increase pain, irritation, inflammation, and then of course increase any possible groin-related symptoms. After you would have any imaging, sometimes doctors will potentially try some cortisone injections into the hip, kind of as a diagnostic test, if maybe the images don't look too serious, or if you're relatively young and they want to try to stave off or hold off any replacements just initially. Once you've maybe tried a cortisone injection or the doctor's like, I don't think this is really an option, we need to consider a hip replacement, then really becomes the biggest question that I get asked with patients that I've been treating is, I've heard a lot about 2 different replacements, which one do you think I should do? So the 2 main surgical approaches are the anterior and the posterior. So we're going to talk about the posterior approach first, just because it's the most common. It's just more traditional. Most doctors do perform that one more than the anterior approach. Again, just because the anterior approach is newer. That's probably only been performed maybe since the early 2000s, so still sounds like a long time, but in terms of medicine and hip replacements, that's still relatively new. So in terms of the posterior approach, when a doctor goes in to perform that procedure, they're going to go in through the posterior or the back side of the hip. It's not directly down the back side, it is more a little bit on the lateral or on the side portion. So again, here is our hip. So you have your pubic bone in the front, and then this is the back where your big glute muscles would be. They generally will make an incision just along the back side of your hip here. So one of the pros of this procedure is because it is more traditional and it's more long-standing. So because it's been around a lot longer, most doctors are very comfortable, have performed hundreds to thousands of them before they've done yours. And that's always nice to know that someone has done them multiple times before you would have your hip replaced. But most people tend to focus on the negatives, unfortunately, when it comes to the posterior approach. And that's really the biggest thing that most patients will come to me and talk about is, well, I'm getting a lot of muscles cut. So that does happen with this procedure is when they go in to open up the backside of the hip, there's a ton of musculature that sits right on here. If you think of your glutes or your buttock muscles, they're big, and there's lots of big muscles and then a lot of small rotator muscles that all help control your hip. So those muscles do get cut to go in and expose the actual joint so they can replace, again, kind of that ball and that cup, because they will replace both pieces. So when they have to cut those pieces down, they do repair them before you come out of surgery, because you do need that support and that stability in your hip. But there is kind of that negative downfall that there is a little bit more damage that happens during that hip replacement surgery. Aside from the muscles that are cut, there's also precautions that come in afterwards, which that's the second biggest thing is people will tell me, well, I don't want to have any precautions after I have a hip replacement. So the precautions meaning because they had to cut through the back of the hip, and when they have to expose the hip joint, there's all these thick ligaments and a capsule that helps support and kind of maintain that joint stability that's in your hip. So if they have to cut through all of that, then you're losing some of that just innate structure and innate stability you have. So even though they've repaired everything and you have a good stable hip, there is a possibility you could dislocate with the posterior approach. So there are a couple different rules that doctors will put in place, or at least highly recommended rules that you follow anywhere from 6 to 8 weeks or maybe longer, depending on what actually happened and what they saw in your surgery. So those 3 rules generally are no bending your knee towards your chest, so that's hip flexion, more than 90 degrees. So if you end up pulling up, or that's even getting out of a low seat, so trying to move forward, get out of a low seat when your hip is really seated deep, then that gets you past that 90 degrees or that L-shaped position of your low back to your hip, or low back to your thigh. The other 2 precautions are crossing your legs over. So if your knees go over your belly button, if your knee or foot crosses your midline over your belly button, or if your knee turns inward. So if there's kind of that collapse inward where your knees come together, that's called hip internal rotation. Now, more commonly, just as doctors are getting much better at performing the posterior hip replacement, that it's just people are under anesthesia a lot less, there's less tissue being disrupted, that the precautions are not as strict as they used to be. You could not do each individual one, but now many doctors, and based off of minor changes in surgical approaches, they have modified it to where you can't do multiples. So you can't combine hip flexion with internal rotation, or hip flexion with crossing that foot over the midline of your body. So when it comes more to the combinations, you can still do a lot of your daily activities and do most things you want to do in a day without much compensation, which is great, which we're always looking for a way to kind of get better faster after we have a big surgery like that. But of course that all depends on your doctor, so just because I said those certain precautions does not mean that that's what's the case. I've had some people that have come out of surgery and just based off of the way that the bones look or the ways that they had to get all the prosthetics into your hip, that sometimes those precautions will be extended to maybe that 8 to 12 weeks, or you might even have greater precautions than possibly what I stated today. The only other precaution that then is thrown in is, which some people have a harder time with, is the sleeping position. So when we talk about those 3 positions I was just talking about to avoid, when you're sleeping, you generally have to sleep with a pillow in between your legs. And at first, it's not just a pillow you use on your bed, it's a big, we call it an abductor pillow. It's basically a big triangle that you put in between your legs. So you're not really, you can lay on your side, but this big pillow has to be basically strapped between your legs so that your knee does not fall in towards your belly button, because that will just put more stress and more strain on that posterior or the back side of your hip capsule. So aside from those cons, again, there's still huge amounts of positives from having a posterior hip replacement. Again, it's so traditional. Many doctors know how to do it, and they have a great visual of your hip when they do it. So technically speaking, it's a little bit easier than the anterior approach, but again, it definitely still has its cons as well. So now when we move into talking about the anterior approach, anterior means front. So that is, like I said, newer, probably since early 2000s, maybe a little bit before then, but that's kind of when it really started coming out. It has not spread as quickly, I would say, as maybe some of the posterior or other surgical techniques, because it does take a high level of skill. So when you're looking for somebody to perform an anterior hip replacement, you really want to make sure that you have a doctor that has done multiple of them and has had extensive training in it, just because it is a little bit different. And when you do the anterior approach, there's not as big of a visual as to where they can see the hip joint itself. So that's where the high level of technicality comes into it, is there's not as much of a visual, and there's a lot more of retracting. So that means kind of moving pieces out of the way because nothing is cut. So again, there's one pro and one con. One con, again, it's a higher level of technical skill, but one of the pros is that there's actual no muscle cutting, which again, most people say that leads to lower pain levels, which means less pain relievers, you sleep better, possibly get back to your activities a little faster, and since there's no muscles being cut, then there's less of a chance for dislocation because you're not really altering that true stability of your hip. But then when we go to the cons, again, I was talking about the high level of technicality. It's still a newer surgery. So despite the fact that it's, again, maybe almost 20 years old, if not maybe a little longer, I'm not quite sure 100% when it started kind of coming into practice, but it's still technically new. So we have some longer standing data, but not anything significant that would really tell us how people are really faring, anterior, posterior. There are some research studies, but not a ton to really correlate or look at the differences between the two. But then you also do need, as a surgeon, special equipment. So there's different tables. So there are certain surgical centers that are more inclined to be able to give you the anterior approach if that's something that you want. Now, with this surgery, one other con is that there is an increased risk for nerve injury. So where are they going through the incision? Again, if this is the front of your hip, again, here's your pubic bone, here is your thigh bone, that they'll start the incision right here along the front of your hip area. If you think of those pointy bones in the front of your hip, we call it the ASIS, or the iliac crest. They'll start the incision there and move downward. There is a nerve that sits laterally in that area that only deals with sensory, so it's not a motor function if for some reason that nerve gets affected. It won't necessarily affect any person's motor output. It will just be more of a sensory sensation where you'll have some paresthesias or some altered sensation along the outside lateral portion of your lower leg or of your upper thigh. So aside from the nerve injury and the equipment and medical technicality, there are a ton of pros that really can help you, at least in your overall process. Again, there's less muscle cutting, which means possibly faster recovery and less medications, which really can help you long term and get moving a little bit faster for people that are looking for less downtime after a hip replacement. Now, after you've had a hip replacement, whether you've done or chosen to have a posterior or an anterior, there's a couple things that I think are important to note when you are coming out of surgery. Most places do perform what's called a joint camp now, or will give you a large packet of information of what you should know before you have your joint replaced. Generally, they'll talk about things to expect, so pain levels and using an assisted device, how to and when to start setting up some physical therapy, and that stuff should not be taken lightly. I always tell people the more you know going in, the better you're going to feel coming out. Is if there's any surprises where you didn't know you had to use a walker, you didn't know you had to use a cane, that adds to more stress after surgery, which you really want to emphasize the least stressful environment you can. Is no matter what, a hip replacement or any joint replacement for that matter is a painful process. And the first 2 weeks, I always say, are the worst. Once you get through the first 2 weeks of initial healing, things do start to look like they're going to get better, but in those first 2 weeks, it does seem pretty, kind of dim, or I don't want to say dim or dismal, but it does seem like there's maybe no light at the end of the tunnel. But probably about 2, maybe 3 weeks, things start to turn around. So the least amount of stress you can give yourself afterwards is going to be more beneficial for you in the long run. So again, I was talking about assisted devices. So most people go home with a rolling walker right after surgery. And they're advised to utilize that for usually up to 2 weeks. Usually, again, because that's when you have a higher level of pain reports, and we want to make sure that you're moving around, but that we're controlling your pain within a normal level. So you can sleep, you can get some rest, because sleep is one of the most restorative things that you can do after any injury or any surgery. After a couple weeks, once pain comes down and you start to get a little stronger and more steady on your feet, then we start to transition to a cane. One that helps with better muscle development because you're using more of your leg to control your motion, but also it kind of starts to help you get back to more of your normal life, but still with some stability. I usually tell people after a couple weeks if they're doing okay and if I see their gait mechanics are relatively normal, I still like them to use a cane out in public because it just gives people an awareness of kind of where you are in space and maybe they need a little bit more room. So if someone doesn't bump into you at the grocery store or if you're out to dinner or something, it does give people some level of awareness of try not to get too close, please don't bump me, I'm a little unsteady on my feet. Now, as I mentioned, sometimes in joint camp they might recommend PT or might not. As I have a lot of patients that say, well, I think I want PT, but my doctor said I don't need it after surgery. So there was a pretty large research study that came out, I don't actually recall when it came out, but they did talk about how they looked at people post hip replacement that had PT and did not have PT, and they found that the people pretty much ended up at the same spot about, I think it was 6 months, maybe 3 months, in relation to pain in both functional level. So after that study came out, everybody's like, well, we don't need to order PT after hip replacements because people always end up in the same spot afterwards. And I do think there is a valid point to that. I do think, to an extent, some people don't need as much therapy if you're relatively self-driven and I don't want to say stay motivated, but your hip replacement is still a hip replacement, as you're getting a joint replaced, and if you have any other issues going on in your body, I think it is a valid point to possibly ask your doctor for any sort of prescription if you need one, because we have direct access in Wisconsin, and if your insurance allows it, we can see you without a physician request, but our first physician prescription. But I still think it's important to keep the doctors in the loop. So patients that I have seen or have asked for PT is if they have a history of back pain, like pretty significant sciatic symptoms or low back history where they're starting to feel a little off, maybe, where their hips just feel a little uncomfortable, their back feels painful. So they want to make sure that they can do certain exercises to keep their back happy while they're going through their hip recovery. I've also had some patients that have had histories of knee issues, foot ankle issues, even neck issues where maybe they're having more headaches from using the walker or possibly not sleeping well. So if they're not sleeping well, their head's kind of coming forward, maybe having a little bit more neck, shoulder pain. So just because the doctor said you don't need physical therapy for your hip doesn't mean there's other body parts that can't be taking a beating as you're going through your recovery or healing post hip replacement. So in this instance, that's where I say don't be afraid to ask. If you do need any help, I always say I'm happy to ask or at least talk to the doctor just to say why you would need it perhaps. But if I do see someone after a hip replacement, I'm not trying to see them for 3, 4, 5 months unless there really is a significant issue that's developed aside from their hip. It's usually just a small, 4 or 6 visits just to make sure that you're getting on the right track, that you're doing your home exercises correctly, and that you're truly, again, moving on the right path and kind of understand what's going on. I think the first two weeks to even the first 8 weeks can almost be a little scary because you just don't know what to expect if you've never had a joint replacement before. So it is totally normal to have those higher level of pains in the first 2 weeks, but they do tend to gradually go down. But I always tell every single patient that's had a surgery that your recovery is never going to be just a straight trajectory upwards. It's always going to be up, down, around, everywhere. And you're going to have good days, you're going to have bad days, but just knowing that as long as every day gets a little bit better or every 3 days gets a little bit better, you're still going to be moving in the right direction. So that's it today for all the information I could possibly give you in a short amount of time on hip replacements, and have a good day.